Hi, everyone. Going to give us just a few seconds. My name is Kayla Fulginetti. I am the Senior Director at Adolescent. Very excited to welcome you to Session 2 of AYA Power. Just a very brief introduction. POWER is the partnership between the AYA Oncology Education Working Group and Adolescent to really bring education and fill the gap as far as our providers who are treating or encountering or just being with adolescent and young adults diagnosed with cancer. These monthly webinars, like the one you're at right now, are all going to be about relevant topics for AYAs and that population. So we are very excited to be offering these to you. Both live, as you are here today, and as well as recordings and additional resources that are going to be available on our website through elephantsandtea.com. A couple just very brief housekeeping before I pass it over to our speaker today. This talk will be about 20 to 30 minutes, as all of our sessions will be moving forward. If you attended the first session, that one was a little bit longer because we wanted to provide a very good comprehensive overview, but these next sessions moving forward will be about 20 to 30 minutes with the opportunity for questions at the end. Because this is a webinar, we do have that Q&A feature, so we would love questions to be dropped in there, and we will work on getting those addressed at the end of the presentation. The chat is also open, so please feel free to have conversations in there. And as you might have heard when you joined, this is being recorded, so just a reminder again that our website really is going to be the hub for AYA Power, where this will be available in the next day or so, and you'll get an email when all of that is up and running, as well as additional resources and information that will all live on that website so that people will be able to access that at any time. I am very excited to welcome our speaker and introduce him. Dr. Mike Roth is a professor of pediatrics, the co-director of the Adolescent and Young Adult Program, director of the Childhood Cancer Survivorship Program, and member of the Leukemia Lymphoma section at MD Anderson Cancer Center. Within the Children's Oncology Group, he is the chair of the AYA Oncology Discipline Committee, and in collaboration with many others, he's helped MD Anderson build the largest AYA program in the nation. His research is focused on identifying and addressing disparities in care and outcomes for AYAs diagnosed with cancer, and he has a particular interest in improving the long-term health and quality of life for AYA cancer survivors. With that, I will hand it over to my wonderful friend, Mike Roth.
Thank you, Kayla, very much. Thanks for just your partnership and really making sure that everyone has access to this AYA education curriculum. So today we're going to focus on disparities in AYA cancer care and outcomes. And this is going to be an overview of a lot of different disparities that we've seen through the years. We're going to do this as sort of a quick 20 minutes, then open it up for questions. Please note, if you do want to dive deeper into any of those topics, you can reach out to me, and we can also have a future session on some of the specific disparities that you'll see. I do not have anything relevant to disclose. And this is what we're going to cover today in the next 20 or so minutes. So we're talking about disparities across the cancer continuum for AYAs. These disparities may occur at initial diagnosis, while on treatment, off treatment, and post-treatment survivorship. We'll talk about disparities or differences in outcomes across the AYA cancer population, looking at different disease groups, but also within the AYA cancer population, looking at sociodemographic variables that impact survival and health-related quality of life. So let's start with disparities in early cancer survival outcomes. Here's the good news. So the good news is that 5-year overall survival for AYAs diagnosed with cancer has improved meaningfully over the past few decades. So recent SEER data quotes about an 85% 5-year overall survival for all AYAs diagnosed with cancer today. If you compare outcomes in the 1970s to the early to mid 2000s, you can see a significant increase in survival for our AYAs for both male and female patients. Unfortunately, these improvements have not been equitably distributed across all disease groups. So approximately 10,000 AYAs will die from cancer each year in the United States. And the most common cancers contributing to these outcomes include breast cancer, CNS tumors, colorectal cancer, and leukemia. And if you look at the figures on the bottom of the slide here, you can see that there are specific diagnoses where we've made minimal gains in survival over the past number of years, specifically struggling for patients with CNS tumors, colorectal cancer. You're not seeing on the slide here, but patients with sarcomas as well. If you look at osteosarcoma, we still use the same treatment that we used 40 years ago for these patients, and survival outcomes have not meaningfully changed. I want to talk a little bit about where AYAs receive their cancer care and how it impacts survival outcomes. What's interesting about the AYA cancer population, and also a challenge, is that they receive their care across multiple care settings. They may receive their care by a pediatric oncologist versus a medical oncologist. They might receive their care in a community oncology site or an academic site. And with all of the diversity in these sites, it means that often care is not standardized, and the treatment as well as supportive care may be different for AYAs depending on where they receive their care. With increasing age, AYAs are more likely to be seen by a medical oncologist, be more likely to be seen in a community as opposed to an academic site. And this is really important work by Julie Wolfson, who showed across multiple disease groups that AYAs treated in the academic setting, typically by pediatric oncology, is more likely to have a higher survival. And this is true in acute lymphoblastic leukemia. We also see this with patients with CNS tumors. These data have been replicated in patients with sarcomas as well. And the reasons behind these disparities are really unclear, and a number of investigators are trying to fill this gap and intervene and understand what can we do to narrow the disparity in survival outcome between community and academic sites. We do know that many AYA diagnoses are rare cancers, and it probably requires specific expertise in treatment approach and supportive care to maximize or optimize outcomes. As has long been known, sociodemographics plays an important role in survival outcomes for AYAs with cancer. This is data from the Texas Cancer Registry, which looks at AYAs diagnosed with cancer in the 90s compared to the early 2000s. And it looks at patients' location in terms of whether they're rural or urban, their socioeconomic status or their poverty status, as well as their race and ethnicity. And what is highly concerning is that patients with low socioeconomic status and those who are non-Hispanic Black and those who are Hispanic have consistently poor survival compared to those with higher socioeconomic status and those who are non-Hispanic white. What is incredibly concerning is if you look at the male and female non-Hispanic Black population, survival for patients who are non-Hispanic Black in the early 2000s still has not caught up to survival for those patients who are non-Hispanic white in the early 1990s. So while everyone is making gains in their survival, we're actually not closing the gap, and we continue to have these persistent disparities, which means that progress needs to actually be targeted specifically for our patients who are underserved. If you take a step back and look at outcomes for patients shortly after they're diagnosed, we see additional disparities by cancer diagnosis as well as by sociodemographics. This is SEER data that we looked at, and we considered early death to be death within 2 months of diagnosis. It's important to note that prior studies have shown AYAs are more likely to present later in diagnosis with more advanced disease or higher stage disease. What you can see in the figure here is that there are a few cancer types that are associated with very high risks or rates of death within 2 months of diagnosis. Acute myeloid leukemia, patients often come in very sick, require very intensive treatment. Approximately 10% of all AYAs diagnosed with AML will succumb to their disease within 2 months of their diagnosis, of their presentation. And then there are other cancers that are more commonly seen in adult patients or older adult patients, such as GI cancers, as well as lung cancers. And you typically would not expect these AYAs to have these diagnoses And the assumption is that these patients are presenting with very high stage disease very late in the game. If we look within the hematologic malignancies, the population who has the highest risk of early death, we see disparities by race, ethnicity, as well as socioeconomic status and insurance. Hispanic and Black AYAs with hematologic malignancies have the highest risk of early death compared to non-Hispanic white AYAs, as well as individuals with lower socioeconomic status and those who are uninsured. These patients also have significantly higher risks of early death. So the next question is, what can we do to potentially address these disparities in survival outcomes? And insurance is a key factor that you saw on the last slide. So this is a little bit of a complicated study that we did a few years ago utilizing SEER analysis or SEER data. And the analysis we did is we tried to isolate the impact of the Affordable Care Act's dependent care expansion, the DCE. And what this did is this allowed AYAs to remain on their parents' insurance up through age 26. And we developed a sort of an experimental group, which is the middle AYA. These were the patients, the individuals who were most likely to be impacted by the DCE, meaning they would be able to have their insurance extended. And we had two control groups, a younger patient control group who would always be able to remain on their parents' insurance, as well as an older AYA population who were beyond age 26 and the DCE would not impact them. And what we looked at is 2-year survival post the dependent care expansion. And you can clearly see that the middle AYA population had a significant improvement in their 2-year survival with the implementation of this law. What was really exciting is that when we looked within the patients who benefited the most, it is those patients who identified as Hispanic and those who had the lowest socioeconomic status. They had the highest improvement in their 2-year survival, clearly showing that improving access to quality care can improve short-term survival. So we're going to jump around a little bit and now talk about disparities in participation in cancer clinical trials. And this is really important because cancer clinical trials are how we make improvements in survival. The trials are utilized to identify the best treatment approach as well as the optimal supportive care approach. You can see on this slide the ideal curve for clinical trials. So this is for children with acute lymphoblastic leukemia. And what you can see is that every single trial with every decade, we saw impressive improvements in overall survival, to the point where in the 1950s, survival for children with ALL was less than 10%. 5-year survival for children with standard risk ALL today is about 95%. So we've made a lot of improvements. The challenge that we have for AYAs is that very few AYAs historically participate on cancer clinical trials. The figure on the top left shows AYA participation in NCI-sponsored clinical trials by age. And what you can clearly see here is that while many children younger than age 15 participate on cancer clinical trials, there's a valley in participation as you get into the AYA years, with AYAs in their 20s really not participating on clinical trials to a meaningful extent. Because AYAs are not participating or have not historically participated on these trials, it really has prevented us from making progress in identifying the best treatment approach for this specific population. The figure on the right shows the proportion of total patients in that age category who participate in trials. And while you might note that in the AYA age population, they participate at a similar rate as older adults, the challenge is that the denominator is completely different, meaning many more older adults are diagnosed with cancer. So we actually need a higher proportion of AYAs to participate in order to have enough of a sample size to power our studies and get real answers as to how best to treat our AYAs. In addition, if patients do not participate on trials, we have a lack of access to biospecimens. We cannot identify novel targets, and it makes it more difficult to really move the needle and improve the science, and most importantly, obtain more cures. Now, most folks focus on survival when they talk about disparities. And I want to talk a little bit about health and quality of life, because while we now have about 85% 5-year overall survival, life during and after cancer matter, and they matter to all of our AYAs, but it's not talked about enough. So many of you on this call know, whether from personal experiences of being an AYA or knowing others who've been impacted by cancer as an AYA, life is challenging, even without cancer in this age range. Individuals are, really focused on certain milestones in their lives, whether it's education, forming relationships, developing a family, developing their careers. And cancer really throws a wrench into many of these things, if not all of them. We know from great work by Dr. John Salzman and others that AYAs definitely have impaired health-related quality of life during and after treatment. Many AYAs experience distress in some of the domains that you see here, both psychological distress as well as physical distress and limitations. And often for many patients, this distress persists beyond treatment and can persist many, many years after they've finished their cancer treatment. It's important to note that the main disparity for our AYAs in regards to measurement of health-related quality of life is that most of our studies actually don't assess quality of life, and many of our providers are not assessing quality of life in their patients. And we have to do a lot more work to ensure that our patients know that their quality of life matters, and that we as a community are doing everything we can to address their quality of life and improve their health and happiness both during and after treatment. In regards to quality of life, for many individuals, growing a family is an important life goal and milestone. Unfortunately, we know that fertility can be impacted by cancer diagnoses and cancer treatment. Specifically, surgery, radiation therapy, and exposure to alkylating agents can put patients at very high risk for having trouble having biologic children in the future. What's really concerning is we have opportunities to preserve fertility for many of our AYAs, but most AYAs never receive any counseling or education prior to their cancer diagnosis that these options exist. Things like sperm banking, oocyte, and embryo preservation, these are options, and even though there are barriers to some of these preservation approaches, the most important thing we need to do is make sure that every AYA is educated and has access and is involved in the decision-making process of whether they want to and can go through with fertility preservation before and/or after they complete treatment. Why do AYAs get cancer is always a question that I get in my clinic. For some AYAs, there is a cancer predisposition syndrome, whether it's Li-Fraumeni or others. There are many AYAs with early onset breast cancer, patients who are developing sarcomas, who do have this cancer predisposition. Unfortunately, most of our AYAs who are at risk for cancer predisposition syndromes never actually meet with a genetic counselor or get genetic testing. The figure on the right shows AYAs with a personal history of breast cancer who meet NCCN guidelines for genetic testing. And what you can see with the different categories on the bottom is that less than 20% of early onset AYAs with breast cancer ever get genetic testing. And this is a population where it's clearly defined and known that they have a high risk of having a genetic cancer predisposition. You can imagine that for other AYAs, the rate of genetic testing is significantly lower. There are many barriers to genetic testing, but there are also opportunities to increase genetic testing, such as utilizing telegenetic services or telehealth to increase access to central resources. And then we also move towards cancer prevention. The HPV vaccine is highly effective. It's over 95% effective in preventing HPV-related cancers. We know that our AYA cancer survivors have a higher risk of developing HPV-related malignancies, yet very few of our AYA cancer survivors ever initiate or complete the HPV vaccine series. We're going to conclude the talk focused on long-term health and survival outcomes. We started talking about short-term, we shifted gears and talked about health-related quality of life. Now we want to talk about what happens to patients years after their diagnosis and their treatment completes. This is data from our MD Anderson tumor registry, where we looked at the long-term survival of 5-year survivors of AYA cancers. So if you look at the figure on the left, the x-axis starts at 5 years from diagnosis, and we looked at survival compared to the predicted survival of the US population. What you can clearly see is that in years 5 to 10, there is a steep decline in survival, and this is likely secondary to disease recurrence or persistence of their disease, of their primary disease. But after that, the slope of the line continues to decline, and these patients are likely dying from late side effects of treatment. 20 years after diagnosis, there's another 25% of patients who have passed away of those who survived 5 years, and that is highly concerning. There is some good news on the figure on the right. It looks like survival is improving long-term for our AYAs. However, this may be secondary to more durable cure rates, and while the slope of the curve improved between years 5 to 10 years, beyond that, I'm not convinced that the number of late effects will decrease, although there is some hope that the use of radiation has decreased in some populations, such as those with Hodgkin lymphoma. If we narrow in and focus on AYAs with acute leukemia, this is ALL and AML, you see a similar curve to what we saw on the last slide. In blue, you see AYA survivors with AML. And what is interesting and concerning is that 15 years post the 5-year survival mark, the lines cross, and those with AML, their survival decreases at a more rapid pace. And what I think is happening here is that many of these patients received a stem cell transplant, and these patients are dealing with the late side effects of that transplant and having early mortality due to total body irradiation and other components of the conditioning regimen. If we look at the cause of death in these patients, what you can clearly see is that in the first 5 to 10 years beyond the initial diagnosis, these patients are dying from their initial acute leukemia. But at about 15 years, the cause of death changes, and it's death by other, which is typically death by late side effects. It's not just mortality, it's also health that matters. We clearly see that AYA cancer survivors have a very high risk of developing chronic health conditions, and they have a high risk of developing not one, but multiple chronic health conditions, and many of these can be severe or life-threatening, including cardiac morbidity. We also see that Black and Hispanic AYA survivors have the highest rates of developing these chronic health conditions, contributing to higher rates of early mortality in our long-term survivors. These are data from Kaiser Permanente and looking at various disease types in the AYA population. If you focus in on the leukemia population, this is the cumulative incidence of cardiovascular disease in cancer survivors compared to patients without cancer. And what you clearly see is as you get further and further away from treatment, the risk of cardiovascular disease increases significantly in our cancer survivors and to a much greater percent compared to those patients or individuals who never experienced cancer. And these are age-matched controls. If we look within our population and look at sociodemographic disparities in developing cardiovascular disease, we see, as expected, males are at a higher risk for developing cardiovascular disease compared to female patients, and this is in the AYA cancer population as well as AYAs who never developed cancer. Household income matters, lower socioeconomic status and means. Those with a household income of less than $50,000 have a significantly higher risk of developing cardiovascular disease. And then we also see within our AYA cancer survivor population, Black survivors in particular have a very high rate of developing cardiovascular disease. On the flip side, we actually have recommendations for how to screen and identify and assess and treat our cancer survivors in regards to what risks they have based on their exposures. These guidelines are available for all providers and patients, and these are developed by the Children's Oncology Group long-term follow-up guidelines group. These guidelines are recommended for children, adolescents, and young adults who are survivors of cancer. Unfortunately, very few AYAs ever receive any survivorship-directed care. Post-treatment cancer survivorship care should focus on the screening and prevention of long-term side effects of treatment, as well as the prevention of secondary cancers. But most AYAs, when they complete cancer treatment, they go off into the community. They may or may not obtain a primary care provider. And then years later, many of them unfortunately face the late side effects of treatment and then come back into medical care only when they've had health issues. We need to increase access to survivorship care for all AYAs and do it equitably. So in conclusion, and this has, I think, been a whirlwind of different disparities in AYA oncology, we have made great progress, and we're continuing to make great progress in our survival and quality of life outcomes for our patients. And it's thanks to all the hard work all of you are doing. AYAs diagnosed with cancer continue to face disparities in short and long-term survival, in short and long-term health and quality of life. And we need to address these disparities and not just accept that they exist. Local and national initiatives are needed to both identify the disparities, but also we need to work faster and really do a better job addressing these disparities and making sure that all AYAs have the same rate of improvement in their health, quality of life, and survival. I want to thank you very much for your time. I want to thank AYA Power for giving me the opportunity to talk with you guys. And please reach out anytime. Here's my email address, and I'd be very happy to take any questions.
Thanks, Mike. That was a great overview. We do have some questions in the chat already, which do surround trial participation. Questions about barriers to trial enrollment. What's the reasoning behind poor enrollment? Is it due to availability of clinical trials, patients not eligible due to their age, not being offered clinical trials in the community or adult settings?
Yeah, that's a wonderful question, and I particularly appreciate that because it's been really a focus of my research for the past decade or so. So really, it's all of the above. There are a lot of barriers, and historically, there have been a lot of barriers to AYAs being able to participate in trials. The first barrier historically was not having enough relevant trials available for AYAs. We have been addressing this in some of our national organizations, developing specific trials for AYAs where both pediatric and medical oncology collaborate to develop trials for patients with Hodgkin lymphoma, with sarcomas, and with many other relevant AYA cancers, such as germ cell tumors. There are definitely site barriers to opening these trials specifically. If you think about our research offices and financially, whether it's more rewarding to open an older adult breast cancer or prostate cancer trial, they can enroll in a year or 2 years the same number of patients. It could take 10 years to enroll AYAs on a study. So many sites are not prioritizing AYA studies specifically. Many sites do not have screening approaches in order to identify AYAs who are available for studies. Some providers feel uncomfortable offering studies to AYAs, and we don't know a lot about AYA barriers to participation yet at this time. There are a variety of national initiatives focused on improving site or addressing site level barriers, and feel free to reach out to me, or if I'm invited back, I can spend a whole session talking about clinical trial enrollment. But I agree with you that this is the way we make progress, is through clinical trials and making sure that AYAs have the opportunity to participate, and we can really get the answers as to how best to cure our patients, but also improve their health and long-term outcomes.
Thank you. Those are the main questions that we had in the chat so far. So I'm going to open it up there for a minute and see if anybody had. Oh wait, just another one came in. When young adults present, usually in their 20s, it's often difficult to treat when they're acutely ill due to lack of adult providers in the children's hospital setting. Example of cardiology or nephrology only seeing up to 18 to 21-year-olds. Any suggestions on that?
Yeah, that's a big challenge. So it gets back to one of the earlier slides about location of care and the silos that we have between pediatric oncology and medical oncology. And for some children's hospitals, they'll in the oncology floor, they'll treat AYAs up to age 25 or 30 or 35. But then if those patients get acutely ill, the pediatric intensive care unit has a sort of a cap of age 18 or age 21, or on the reverse side, adult centers will see patients who are younger, but their intensive care unit will not see patients who are younger, as well as the specialty services that you mentioned. The key ingredients that have worked has really been collaboration and communication. So probably one of the biggest barriers to providing optimal care for AYAs has been the lack of communication between pediatric and medical oncology. There's a number of sites who have had really wonderful collaborative approaches where pediatric and medical oncology have joint tumor boards, they share patients, they screen patients for trials together, they identify whether patients would be better served on the pediatric or the adult side, irrespective of age. So there's no one size fits all, but it's really looking at your local institution and having those conversations. I'd be happy to share examples on the national level of sites who have done this well. I will not share examples of sites who have done this poorly, but there's really an opportunity to do better for our patients. It takes a champion on the pediatric side and the adult side to really want to move the needle and improve care and outcomes.
Yeah, thank you. And I think that part of our hope with with this series with AYO Power is to start to develop that network and community of both our pediatric and adult providers, so people start recognizing the names that are kind of logging in and asking questions, and start to really develop some of those relationships locally, but then also regionally and nationally in terms of trying to really tackle this both on the ground in the hospitals, but then also from a research perspective, like Mike was talking about, in terms of really trying to answer some of these questions. So we hope that this is the beginning of that. And as we continue these series, that people start to interact more and get to know each other to develop that. Another question was about income. So on one of your slides, you seem to show data that higher income reduced the impact of cardiovascular disease in AYA survivors. Is the solution just to give people more money? Sure. But seriously, are there data regarding reduced disparities in this setting, i.e. focused interventions, having an AYA program, or treatment at an NCI cancer center?
Yeah, that's a great question. And even though your comment was half joking, it's relevant because we think socioeconomic status is also a marker of lifestyle and physical activity. So we've done some research showing that AYA survivors who have fewer socioeconomic means, they exercise less, their diets are poorer as well. And that's not just true in the AYA cancer survivor population, that's true in the general population as well. I think the way we reduce disparities is really by equipping as many providers as possible with the knowledge that AYAs are a unique population, they have unique needs, and they need attention. And we need to do this on the local level. I think the reason, like Scott was saying, behind this whole initiative is to make sure all providers have at least some baseline level of knowledge on how best to care for the population. The biggest challenge we have is that AYAs get treated, and then for the most part, they sort of are pushed out into the community and then don't ever receive any AYA-specific care in terms of survivorship care. So if we're thinking about long-term outcomes, I think the biggest challenge is that we treat them the same as everyone else and would not think a 35-year-old would have a risk of developing congestive heart failure, but they received 500 milligrams per meter squared of anthracyclines or received chest radiation, and their providers aren't doing echoes to catch preclinical cardiac dysfunction and dealing with that early. And that's one technical sort of response. But I think the first step in the way we address these disparities is to care and to show we care and put effort and time into making sure that all AYAs have access to AYA-focused care. And that may be a little bit broad. There's a number of initiatives that are trying to connect patients to survivorship-focused care. There's challenges at the beginning of diagnosis and the end of diagnosis. I don't think it's going to be feasible to educate all primary care providers on sort of catching AYA cancers early or cancer in AYA early, just because they see so many patients. But the increased incidence of colorectal cancer, as Dr. Hayes-Latin showed on the last talk, it's really concerning and troubling. And hopefully folks are paying attention, and it's in the back of their mind that we need to give special attention to this population.
Thank you. Another question came in is, what is the ideal model of care for AYA survivorship care? And are there models of care or guidelines right now that can be standardized?
Yeah, that's a great question. So we're actually writing a review on this topic right now. but it's too early to share that review with you. So there's many different models of survivorship care. There's the pediatric approach where you stay within your institution and you stay within a hospital-based survivorship program, for some indefinitely, for others you transition at a certain age group. I don't think this model is really feasible in most adult cancer centers or cancer care settings. I'll use my own cancer setting at MD Anderson. We have over 100,000 cancer patients. We have 15,000 AYAs with cancer, and there's really probably not enough ability to care for patients on active treatment and 20 years post-treatment within the cancer care setting. Our community sites are just as overwhelmed in terms of treating patients with newly diagnosed and relapsed refractory cancer. So my personal recommendation and bias is to make sure that you start by providing some survivorship care within your institution, within your program, and have a plan for transition to community-based providers. Whether it's feasible to have by region providers who have expertise in survivorship care, or you communicate with the community providers and say, this patient got a lot of cardiotoxic meds and they need an echo every so-and-so years, or they had chest radiation, they need mammography starting at this age. I think right now we're starting from essentially zero. So anything we do would improve survivorship care. And I worry about most folks just getting any survivorship care as opposed to one patient getting the gold standard best survivorship care. There's adult models of survivorship care, which I think we can follow and implement, but to be honest, survivorship care is not optimal for anyone right now, even for our childhood cancer survivors who over time, they get lost to follow-up and often don't get the cancer screening and late effect screening that they deserve.
All right. I think those were all the questions that we had in the chat as of now. Is there anybody else who had any others?
Mike, I actually wanted to ask a question. First of all, thank you for the presentation and all of the information. I think for me, when I hear things like this, though, I want to do something about it. I want to make a change. I want to make a difference. Some of these statistics are so disheartening and startling. And so just kind of thinking if there's one thing, you know, that somebody can do walking out of this that might feel like they're moving towards helping or making a difference, is there anything that you would suggest as that thing?
Yeah, that's a great question. I think the most impactful thing you can do is be an AYA champion in whatever environment you work and live in. So if you are a medical oncology fellow right now, look around your institution, look around your department, your division, and are there folks focusing on the AYA population? Ask around, ask what are we doing to specifically support the health and quality of life of these AYAs. If you're a more senior investigator, look at the leadership and speak with the leadership and say, we need to do more for these patients. All of us in all of our institutions and all of our communities can do more. And just shining a light on the population like we did today is meaningful. And often that draws enough attention for folks to start to bring resources together like psychosocial support, or start to look at your own survival data within your population or the trial portfolio. Can we increase the number of trials we open for AYAs? I think that's a really great question. And it's a really great way to end this talk because it's not about describing these disparities. It's really about addressing them and mitigating them and making sure that we're doing better for all AYAs.
Another quick question came in the chat. Are there any AYA peer networks that providers can endorse to provide a sense of community for cancer patients and survivors?
Yeah, that is a wonderful question. So we have a very large AYA program within MD Anderson. We started about 5 years ago. We see about 1,700 AYAs each year, and we give them all the same resources and the same access to these resources. If you want to email me, I'll put my email in the chat. I'm happy to share these resources with you. I'm happy to share them with Kayla and Nick. You know, for example, Adolescent is one of those great resources that's developed a fabulous survivorship community. But there's many of them. And one of our big challenges is getting our patients and survivors access to those resources because they exist. So please do reach out and we'd be happy to share these. And to be honest, part of the education initiative here, it's a great idea to start sharing more of these resources, and that alone can make a difference.
Another question, have there been any strategies that have worked in educating community providers in order to support transition out of institutional survivorship programs?
Yeah, so there have not been many AYA-specific survivorship studies or strategies. Kevin Effinger, who is an outstanding childhood cancer survivorship provider and investigator, he's developed a community of family practices who participate. This is at Duke, and he's developed sort of a model to do so. I think a number of us are trying and hoping to do this to show models that are feasible, acceptable, and are not burdensome. But we're not there yet in terms of having the optimal or ideal model how to do this. My belief is communication is key. Communicating with the patient and the community provider can really make a big difference, because survivorship care, and I am a survivorship doc, it's not rocket science. There's guidelines, there's approaches, there's recommendations. We're just not implementing them. So I think there's a lot of work to be done, and that really is the next stage in AYA survivorship research.
And then another comment and question, having a dedicated social worker in the AYA survivorship clinic is critical, but know that resources are limited. Do you have specific data or resources to support the critical need to have social work see each patient in the clinic?
Yeah, if I just answered yes, I don't think that would be satisfying to your question, but I fully agree with you. The way we built our program is to have social work as core members of our team. They see every new consultation, and they're available for any patient with distress. The challenge, as you state there, is that, you know, for most social workers, they do not bill. So for a hospital, they provide this service, and it's the right thing to do. But financially, for a program, it's something that many institutions, they sort of spread social work across departments. Often social workers in many institutions are just putting out fires, even though they can really do a ton to help patients in terms of mitigate their distress, help them cope with their diagnosis, and also develop life strategies to move forward, you know, beyond cancer diagnosis. So I definitely did not give you any data to show the efficacy. I can tell you anecdotally, it's worked for the past 5 years and thousands of patients we've seen. And what we've done within the institution is we've amplified the social worker role to state that they are a core member. There's no hierarchy in our clinic. The social worker is as important, if not more important, than the medical provider. And I often say that to the patient. And that's been effective in terms of just promoting that role within our institution.
I love this. Everyone's really engaged. More questions are rolling in. So the next one is about what do you use to screen for distress? The GAD, PHQ, and I'll give a plug here. I'll let Mike answer, but we will have an upcoming session specifically on psychosocial issues. So we might get into that a little bit more, but Mike, anything specific that you use?
Yeah, this is a great question. So I believe Dr. Salzman, who really is an expert on this, will be giving an upcoming talk, I think in the spring, specific on this topic. We use patient-reported outcomes for all of our patients coming into clinic. We use the PROMIS short forms, so depression, anxiety, as well as a few others such as cognition, physical activity as well. So we use a number of the PROMIS short forms to do a quick screen for distress. The institution does have an institutional distress thermometer that we use as well, but for AYAs, we specifically use PROMIS tools, and it really guides our visit to see, are there specific red flags or areas that need to be addressed urgently? Are there other areas that are more long-term issues that we should be addressing? Definitely join for Dr. Salzman's talk in the future. He'll go into all of these details.
And then another question, do you think that there have been more efforts to improve AYA cancer care? Have you noticed in the past years any positive changes in overall care or in specific domains?
Yes, yes, and yes. And I think this is one of those efforts. And it's come out of the fact that, 25 plus years ago, there were a few individuals who recognized these disparities, and they worked their tails off to make this an initiative and an issue that needs to be addressed. We recently had a meeting with the White House Cancer Moonshot leadership. So this actually, AYA cancer disparities, it really does have a voice nationally. There's been a number of efforts specifically in the clinical trials development arena. It's been a game changer. Over the past 10 years, we went from having one collaborative AYA trial that was developed between pediatric and medical oncology to now having many, many AYA trials with many more in development. There was recently a trial, S1826, a Hodgkin lymphoma trial. It was a collaborative trial. They were able to show a 94% one-year progression-free survival for AYAs receiving nivolumab, a checkpoint inhibitor with a standard backbone. So we're moving the needle in certain areas, health-related quality of life, I think, and survivorship. This is the next iteration. This is where we need to go. And this is where I'm hoping that we make more rapid progress.
Then there was a follow-up question about the distress tools that you use. Are you using the new AYA Promise questionnaire?
So we are using the Promise short forms that are not AYA specific. I could put a reference in the chat. We recently published in JNCI recommendations for how to assess health-related quality of life and symptom burden in cancer clinical trials, and that's pretty relevant to what you're asking. I will have to look away and get you the reference real quick. But I would recommend reading that. That's been a partnership with experts across the adult and pediatric oncology world for recommendations specifically for how to assess AYA health and quality of life.
Awesome. Thank you. I think that might be it for questions.
Perfect. Well, I will say thank you to AYA Power. It's a little bit weird because I'm a part of it, so I'm thanking myself as well. But thanks to Adolescent for the partnership, and to all on the call, thank you for joining. Thank you for caring. Please share these talks with your colleagues. We only make a difference if more folks who are in this field are learning about the population and really trying to do better. In addition, all of these talks will be posted to the website. We also have I think it's a 6-minute version of this talk as well as references. So please come back. Dr. Hayes Lattin's talk was wonderful. It was better than mine. So if you thought this was decent, please view Brandon's talk as well.
All right. Thank you, Mike, for a wonderful presentation, and Scott for moderating our Q&A. I'm recognizing that not everyone might know who I am. I'm Nick Galarakis, the Executive Director of Adolescent. So as Mike thanked us, I would like to thank Mike and Scott once again in the AYA education group that we collaborate on for AYA Power. Lisa, our Director of Marketing, has dropped in a couple links for you all to take a look at. One being the survey for today's session. We'll also email that out to everyone that attended. And then 2, we have the registration up and running for the next session, which is on sexual health on October 26th at 12 p.m. Eastern with Dr. Sharon Bober, which we're really excited about. So go ahead and register for that so you don't forget about it later on, but we'll obviously circle back with everyone via email as well. If you'd like to go back and check out our AYA Power page that Mike was talking about, that link is on there as well, plus just the link to our Adolescent homepage. So once again, thank you all for attending. It is an honor to be a part of this collaboration with Mike and Scott. And thank you, Kayla, for leading the charge in the Adolescent side of things. We look forward to seeing you all in October. But as always, if there are ways that we can improve or suggestions that you all have, do not hesitate to reach out to any of us. We are an open door, I'd like to think, on taking constructive criticism like everyone else. So please feel free to do so. Otherwise, thank you again for being here in attendance today. We will let you all know when that recording is available as well for anyone that missed it. So thanks, everyone, and have a great rest of your day.